Bacterial Sepsis in Pregnancy. RCOG Guideline number 64A, April 2012.
Background and Introduction. Sepsis in pregnancy remains an important cause of maternal death in the UK. Severe sepsis with acute organ dysfunction has a mortality rate of 20 to 40%, which increases to 60% if septic shock develops. Sepsis may be defined as infection plus systemic manifestations of infection. Severe sepsis may be defined as sepsis plus sepsis-induced organ dysfunction or tissue hypoperfusion. Septic shock is defined as the persistence of hypoperfusion despite adequate fluid replacement therapy.
Which women are at risk of sepsis in pregnancy? Multiple risk factors for severe sepsis have been identified. Table number 1. Risk factors for maternal sepsis in pregnancy as identified by the confidential inquiries into maternal deaths. Obesity, impaired glucose tolerance or diabetes, impaired immunity or immunosuppressant medication, anemia, vaginal discharge, history of pelvic infection, history of group B streptococcal infection, amniocentesis and other invasive procedures, cervical cerclage, prolonged spontaneous rupture of membranes, group A streptococcus or GAS infection in close contacts or family members, of Black or other minority ethnic group origin. What should prompt recognition of sepsis in the pregnant women? All healthcare professionals should be aware of the symptoms and signs of maternal sepsis and critical illness and of the rapid, potentially lethal course of severe sepsis and septic shock. Suspicion of significant sepsis should trigger an urgent referral to secondary care. Clinical signs suggestive of sepsis include one or more of the following: pyrexia, hypothermia, tachycardia, tachypnea, hypoxia, hypotension, oliguria, impaired consciousness, and failure to respond to treatment. These signs, including pyrexia, may not always be present and are not necessarily related to the severity of sepsis. Regular observations of all vital signs, including temperature, pulse rate, blood pressure, and respiratory rate, should be recorded on a modified Early Obstetric Warning Score or MEOWS chart. All staff taking observations should have annual training in the use of MEOWS or Modified Early Obstetric Warning Score chart. Genital tract sepsis may present with constant severe abdominal pain and tenderness, unrelieved by usual analgesia, and this should prompt urgent medical review. Severe infection may be associated with preterm labor. Toxic shock syndrome caused by staphylococcal or streptococcal exotoxins can produce confusing symptoms, including nausea, vomiting and diarrhea, exquisite severe pain out of proportion to clinical signs due to necrotizing fasciitis, a watery vaginal discharge, generalized rash, and conjunctival suffusion. Table number 2. Clinical features suggestive of sepsis, modified from references 1 and 3. Fever or rigors, diarrhea or vomiting, may indicate exotoxin production or early toxic shock. Rash, generalized streptococcal maculopapular rash or purpura fulminans. Abdominal or pelvic pain and tenderness. Offensive vaginal discharge. Smelly suggests anaerobes, and serosanguinous suggests streptococcal infection, productive cough, and urinary symptoms. What are the appropriate investigations when sepsis is suspected? Blood cultures are the key investigation and should be obtained prior to antibiotic administration. However, antibiotic treatment should be started without waiting for microbiology results. Serum lactate should be measured within 6 hours of the suspicion of severe sepsis in order to guide management. Serum lactate of greater than or equal to 4 millimoles per liter is indicative of tissue hypoperfusion. Any relevant imaging studies should be performed promptly in an attempt to confirm the source of infection. Blood cultures and other samples, as guided by clinical suspicion of the focus of infection, such as throat swabs, midstream urine, high vaginal swab, or cerebrospinal fluid, should be obtained prior to starting antibiotic therapy, as they may become uninformative within a few hours of commencing antibiotics. If the methicillin-resistant Staphylococcus aureus or MRSA status is unknown, a pre-moistened nose swab may be sent for rapid methicillin-resistant Staphylococcus aureus screening where such testing is available. Similarly, prompt imaging may identify the source of the infection, allowing early definitive treatment, and should not be deferred on the grounds of pregnancy. Table number 3. Tasks to be performed within the first 6 hours of the identification of severe sepsis. Number 1. Obtain blood cultures prior to antibiotic administration. 2. Administer broad-spectrum antibiotic within 1 hour of recognition of severe sepsis. 3. Measure serum lactate. In the event of hypotension, and/or serum lactate of more than 4 millimoles per liter, deliver an initial minimum 20 milliliters per kilogram of crystalloid or an equivalent. Apply vasopressors for hypotension that is not responding to initial fluid resuscitation to maintain mean arterial pressure or MAP of greater than 65 millimeter of mercury. In the event of persistent hypotension despite fluid resuscitation or septic shock, and/or lactate of more than 4 millimoles per liter, the following must be done. Achieve a central venous pressure or CVP of greater than or equal to 8 millimeter of mercury, and achieve a central venous oxygen saturation of greater than or equal to 70% or mixed venous oxygen saturation of greater than or equal to 65%. Who should be involved in the collaborative care of women with sepsis? If sepsis is suspected, regular, frequent observations should be made. The use of modified early obstetric warning score chart is recommended. There should be an urgent referral to the critical care team in severe or rapidly deteriorating cases and the involvement of a consultant obstetrician. The expert advice of a consultant microbiologist or infectious disease physician should be sought urgently when serious sepsis is suspected. A modified early obstetric warning score chart should be used for all maternity inpatients to identify seriously ill pregnant women and refer them to critical care on obstetric and aesthetic colleagues according to local guidance. Table number 4. Indications for transfer to intensive care unit, adapted from Plot and Ray of 2008. System: cardiovascular. Indication: hypotension or raised serum lactate persisting despite fluid resuscitation, suggesting the need for inotrope support. Respiratory: pulmonary edema, mechanical ventilation, and airway protection. Renal: renal dialysis. Neurological: significantly decreased conscious level. Miscellaneous: multi-organ failure, uncorrected acidosis, and hypothermia. What are the commonly identified organisms, including hospital-acquired infection? The most common organisms identified in pregnant women dying from sepsis are Lancefield Group A beta-hemolytic streptococcus and E. coli. Coliform infection is particularly associated with urinary sepsis, preterm premature rupture of membranes, and cerclage. Anaerobes such as Clostridium perfringens, or the cause of gas gangrene, are less commonly seen nowadays, with Peptostreptococcus and Bacteroides species predominating. What empirical and specific antimicrobial therapy should be used to treat the woman? Administration of intravenous broad-spectrum antibiotics is recommended within 1 hour of suspicion of severe sepsis with or without septic shock. If genital tract sepsis is suspected, prompt early treatment with a combination of high-dose, broad-spectrum intravenous antibiotics may be life-saving. Administration of intravenous broad-spectrum antibiotics are recommended within 1 hour of suspicion of severe sepsis in the woman with or without septic shock. Table number 5. Antimicrobial choices and limitations of antimicrobial. Co-amoxiclav does not cover methicillin-resistant Staphylococcus aureus or Pseudomonas, and there is concern about an increase in the risk of necrotizing enterocolitis in neonates exposed to co-amoxiclav in utero. Metronidazole only covers anaerobes. Clindamycin covers most streptococci and staphylococci, including many methicillin-resistant Staphylococcus aureus, and switches off exotoxin production with significantly decreased mortality. Not renally excreted or nephrotoxic. Piperacillin tazobactam or tazocine and carbapenems. It covers all except methicillin-resistant Staphylococcus aureus and are renal sparing, in contrast to aminoglycosides. Gentamicin as a single dose of 3 to 5 milligrams per kilogram. Possess no problem in normal renal function, but if doses are to be given regularly, serum levels must be monitored. What is the role of intravenous immunoglobulin or IVIG? Intravenous immunoglobulin is recommended for severe invasive streptococcal or staphylococcal infection if other therapies have failed. Intravenous immunoglobulin has an immunomodulatory effect, and in staphylococcal and streptococcal sepsis, it also neutralizes the superantigen effect of exotoxins and inhibits production of tumor necrosis factor or TNF and interleukins.
High dose of intravenous immunoglobulin has been used in pregnant women and is effective in exotoxic shock, for example, toxic shock due to streptococci and staphylococci, but with little evidence of benefit in gram-negative endotoxin-related sepsis.
The main contraindication to intravenous immunoglobulin use is a congenital deficiency of immunoglobulin A. Actual administration of intravenous immunoglobulin should be through a blood warming device, and hospital protocols for replacement therapy and hematology patients may be used. How should the fetus be monitored, and when and how should the baby be delivered? In a critically ill pregnant woman, birth of the baby may be considered if it would be beneficial to the mother or the baby or to both. A decision on the timing and mode of birth should be made by a senior obstetrician following discussion with the woman if her condition allows.
The effects of maternal sepsis on fetal well-being include the direct effect of infection in the fetus, the effect of maternal illness or shock, and the effect of maternal treatment. The risk of neonatal encephalopathy and cerebral palsy is increased in the presence of intrauterine infection. If preterm delivery is anticipated, the use of antenatal corticosteroids for fetal lung maturity in the woman with sepsis can be considered. During the intrapartum period, continuous electronic fetal monitoring is recommended in the presence of maternal pyrexia, defined as a temperature of greater than 38 degrees Celsius once or 37.5 degrees Celsius on two occasions 2 hours apart, and this should also apply to sepsis without pyrexia. Objective evidence of intrauterine infection is associated with abnormal fetal heart monitoring. However, electronic fetal monitoring is not a sensitive predictor of early onset neonatal sepsis. Changes in CTG, such as changes in baseline variability or new onset decelerations, must also prompt reassessment of maternal mean arterial pressure, hypoxia, and acidemia. These changes may serve as an early warning sign for derangements in maternal and organ systems. There is insufficient evidence regarding fetal blood sampling in the presence of maternal sepsis to guide practice. Attempting delivery in the setting of maternal instability increases the maternal and fetal mortality rates unless the source of infection is intrauterine. The decision on mode of delivery should be individualized by the consultant obstetrician with consideration of severity of maternal illness, duration of labor, gestational age, and viability.
Epidural or spinal anesthesia should be avoided in women with sepsis, and a general anesthetic will usually be required for cesarean section. The effects of maternal sepsis on fetal well-being include the direct effect of infection in the fetus, the effect of maternal illness or shock, and the effect of maternal treatment. The risk of neonatal encephalopathy and cerebral palsy is increased in the presence of intrauterine infection. If preterm delivery is anticipated, the use of antenatal corticosteroids for fetal lung maturity in the woman with sepsis can be considered. During the intrapartum period, continuous electronic fetal monitoring is recommended in the presence of maternal pyrexia, or defined as a temperature of more than 38 degrees Celsius once or 37.5 degrees Celsius on two occasions 2 hours apart, and this should also apply to sepsis without pyrexia. Changes in cardiotocography or CTG, such as changes in baseline variability or new onset decelerations, must also prompt reassessment of maternal mean arterial pressure, hypoxia, and acidemia. These changes may serve as an early warning sign for derangement in maternal and organ systems. Attempting delivery in the setting of maternal instability increases the maternal and fetal mortality rates unless the source of infection is intrauterine. The decision and mode of delivery should be individualized by the consultant obstetrician with consideration of severity of maternal illness, duration of labor, gestational age, and viability. What prophylaxis should be considered for the neonate, other family members, and healthcare workers? Local and national guidelines should be followed in consultation with the local health protection unit or lead for communicable disease control. When a mother has been found to have invasive Group A streptococcal infection in the peripartum period, the neonatologist should be informed and prophylactic antibiotics administered to the baby. Close household contacts of women with Group A streptococcal infection should be warned to seek medical attention should symptoms develop, and the situation may warrant antibiotic prophylaxis. Healthcare workers who have been exposed to respiratory secretions of women with Group A streptococcal infection should be considered for antibiotic prophylaxis. What infection control issues should be considered? Group A beta hemolytic streptococcus and methicillin-resistant Staphylococcus aureus are easily transmitted via the hands of healthcare workers and via close contact in households. Local infection control guidelines should be followed for hospital-specific isolation and contact precautions. Invasive Group A streptococcal infections are notifiable, and the infection control team and the consultant for communicable diseases should be informed.